Thank you very much. I'm honored to be here and delighted to have been invited. The only problem for me is I feel so dumb compared to you all. You don't need a translator. You speak 4 or 5 languages. Most people think I need a translator and they speak my language. So we'll see what we can do from here. So I was actually given the title for this talk, which I found challenging, to think over the last 30 years. Actually, I've been in the profession for 55 years, and then to do it in 40 minutes. So we're going to have a quick run through here. So there's several things that are really important on my agenda, and one of them is this transition in physiotherapy. So going back 30 years, which was about 1980, the identity, as I saw it, of physiotherapy at that time was the emergence of manual therapy to an important part of musculoskeletal management. And I think what was so important about it is that really for the first time, physiotherapists were figuring something out rather than just doing something to treat patients. And but the other side of manual therapy was at the time, initially, it was pretty much passive, without any emphasis on exercise or muscle function. And I had already learned that muscles move joints long before therapists knew how to move joints, because that's the way it was when I started. There was also the McKinsey method, which was sort of a self-manipulation. I'm paraphrasing, of course, all of this. And then the only person that I knew of that was somewhat talking about muscles was Vladimir Yanda, and he had his sort of muscle synergy things and sort of a little bit of muscle training. Where I think we are, the big transition, and this has been a major part of my interest for the profession, is developing an identity. And in 2013, the American Physical Therapy Association declared the human movement system as the identity of physical therapy. And I think this is just really critical, because I think what's so important for us is to be in charge of a body system. Not just people that do things, but have responsibility for a system of the body. And what we have is knowledge of its functions. And the other part that I think is so important about this, and particularly you people related to sports, is that we should be lifespan practitioners. We should be helping to shape the performance of a body from the time people start to move until they can't move anymore. And my analogy is with the dental model. People go to the dentist when they get their teeth, and then they keep going even after they don't have teeth. So it's much harder to get people to move when they can't move. But if we start out early, then I really believe we can reduce the incidence of musculoskeletal pain or put it off for a while. And the other thing that I believe is absolutely critical is that we have to have defined syndromes and diagnostic categories. No one will ever think you figure anything out until you put a label on it. And we've got to get in the habit of having labels. So I think the other thing that we're in the major transition of, and maybe this is wishful thinking, but there's many indications of this, is that instead of a big focus on pathoanatomical problems, is a focus on whether you call it, it's movement impairments. And one form is to talk about pathokinesiology, how some form of pathology induces movement faults. But what I think we should be really in charge of is what I call kinesiopathology, which is how movement induces problems. So this is a diagram developed at Washington University for the movement system. And of course, what's so wonderful about it, it takes in everything. As you all know so well, the musculoskeletal and nervous systems, musculoskeletal being the primarily effector of movement and the nervous system the regulator. And of course, the cardiopulmonary and endocrine systems, cardiovascular systems, which you need to keep the other systems healthy, but they're also affected by movement. I kind of keep saying in America we're doing this experiment. The data's coming in good. The experiment is to limit our movement to elbow flexion and extension, usually with a spoon or a fork. And it does show out that you get obese, and then you get heart disease and diabetes. So that data is coming in really good. Anyway, one of our big problems. The definition of the movement system developed at Washington University is a system of physiological organ systems that interact to produce and support movement of the body and its component parts. And I believe that the diagnosis that physiotherapists should make are movement system diagnosis. They should be ones of this system, just as the neurologist makes neurological diagnosis, the cardiologist makes cardiac diagnosis, et cetera. Okay. And I think it was explained well in an editorial by Paula Ludwig, who's an investigator on the shoulder, very, very good one. And she said, regarding diagnosis by physical therapists, that PTs treat movement-related impairments rather than structural anatomical problems. And using anatomical labels creates a disconnect between the label and our treatment. And the advantage of a movement system label is it's consistent with our identity, our expertise, training, our license, and our treatment. It prioritizes the movement exam, which is where I think things are deficient, and evaluation. And it uses standard kinesiology terminology within our scope of practice. So I'm hoping you'll see the rest of this material falls in line with that. So what do we know now? Well, I think we're beginning to know that movement is really key and can become impaired and cause musculoskeletal pain. This is what I consider the main changes in concepts, at least as I've been around for these 50-odd years, that musculoskeletal pain is not a short-term problem with tissues fully restored to normal with treatment, that the pathoanatomical problem is induced by progressive microtrauma related to degenerative changes in lifestyle and personal characteristics, that movement impairments are induced by neuromusculoskeletal adaptations, and they result in changes in the precision of intra and interjoint motions that creates this microtrauma that leads to macrotrauma. And then I guess the really prevailing question for me, and I hope this is the theory will turn out to be right because it will increase the importance of your roles, is this really the progression of events that eventually results in osteoarthritis? So we have this little model, we call it a kinesiopathological model, and musculoskeletal, nervous system, cardiopulmonary, endocrine systems, et cetera. And I think biomechanics is the critical interface in the interaction of these systems. The inducers of the problem are the repeated movements and sustained alignments of everyday activities. And of course, the modifiers are your own personal characteristics. You get tissue adaptations in muscle performance, imbalanced muscle relative stiffness, and what I call relative flexibility. And then this leads to hypermobility of spinal accessory motions and probably a form of micro instability and then the microtrauma, et cetera. So this is the big picture. And if we fill in a little bit of the details, just to make it hopefully even more clear, that it's everyday activities that give the problem. You get the musculoskeletal changes and the nervous system. I think if I had 50 more years, I'd be so focused on understanding more about how you get what you train. The way you do things you get stuck with, and that's what's hard to change around. And of course, that's what we have to change around. These individual characteristics, structural variations, sex, generalized hypermobility, how active you are, inactive you are, all lead to these adoption of movement and alignment patterns with these activities, and then it gets generalized across all activities. Whether you're sitting at a desk or playing a sport, you have a basic pattern of movement that you are stuck with. You get this specific alteration in joint and alignment movement. Some parts become more flexible than other parts and therefore move too readily. And you get altered loading and the accumulation of stress. So I'm going to try to give you some of the research support behind these ideas, and I've tried to put my focus on what I think are the two key concepts, which are relative flexibility and relative stiffness. So what do we know about these? Well, we have a movement exam with good reliability. This is what Linda Van Dillen's research has put in place for us. So this movement exam, and I'll have some references here, we have pretty good reliability on that. We can classify patients with low back pain into groups based on the direction of their symptoms. So we have patients move their spine as well as move their limbs, see how that causes pain. We let them move in their preferred way. We see that they're not doing it right. We correct it and look at the effect on their symptoms. We've also characterized different features according to this diagnostic category and then examined some features of the model. As I say, relative flexibility and relative stiffness. So the physical examination always starts with standing, sitting, hook lying, side lying, prone, quadruped, and the exam is the same whether you're looking at a back pain, hip pain, or even hallux valgus of the big toe. Because these are biomechanically interacting segments, and you can't take one out without being affected by the others. And then I've just listed how some of the studies that have put reliability behind these examinations. And the classifications, and again, a list of references that support the idea that we can classify people with low back pain according to the direction that causes their symptoms. So what about relative flexibility and relative stiffness? And I think these are really key, and that's why I wanted to kind of focus on them. I believe that they're generic to movement impairments at all joints, not just in the low back, but all joints, shoulder, hip, neck, etc. And that relative flexibility, and as we were saying before we started, one of our challenges in physiotherapy is that so many people use different terminology for the same phenomena. And I'm probably, one of the bad ones as well. But hopefully we'll get it all worked out one of these days. So relative flexibility to me means the intrinsic movement of the joint itself, these accessory motions. And that what I'll try to show you is that I believe that intra-joint motion can become imprecise, and that one of the accessory motions occurs too readily than the others. For example, glide rather than roll or spin. And that that motion also becomes excessive. So it's increased in its range, and it's increased in the frequency of its occurrence. Interjoint movement means when you put it together with another joint, like back and hip, if you bend over and your back flexes more than your hips, then you got interjoint relative flexibility. Okay. And then, so that's one big phenomena. The joint moves too readily using accessory motion. And then one of the contributing factors is what I call relative stiffness. And this is basically the passive tension of muscle and connective tissue. And it's defined as a change in tension per unit change in length. At least this part I didn't make up. This is legitimate. And I think it's best depicted by having a couple springs. And what they never told me when I was taking muscle physiology, I got the idea of those nice curves that said this is the passive tension of a muscle, but they didn't tell me it changed. That took 20 years because I'm swift. Anyway, so if you get a muscle that's this big, it's a lot stiffer than one that's this big. And if you put these in series, the least stiff spring gives. And I really believe that what we've interpreted for so long as muscle shortness is not, it's a relative stiffness problem. Okay, so that's the underlying idea here. And it was little things like during clinical exams that would always bother me. For example, this woman is sliding her hip into extension. And you can see she's only moved about 30 degrees before her pelvis is going into an anterior tilt, as indicated by the movement of my thumb on her ASIS. Well, that cannot be muscle shortness because you have not come close to the end of a muscle length. It's happening much too readily. So I wanted to know why would her pelvis tilt with such little movement of her hip. If this was muscle shortness, it didn't make any sense. So this is an example to me of relative flexibility. Her back moved much too easily with her pelvis. And then I would also be confused because I would test other people who actually had a short hip flexor, but they didn't have an anterior pelvic tilt. So it didn't make sense. This kind of person, then what I also realized is this person did not have back pain, but this person did. So it was the back moving that was the critical issue, not how short a muscle was. That didn't have that much to do with it. Okay, and this was another way in which I cut on to trying to depict this issue. So in this case, if someone flexes their knee and nothing happens here, it's because this spring, we'll call it the rectus femoris tensor fasciae lata, is more extensible than these structures. Well, in this case, flexing the knee causes anterior pelvic tilt because the support from the abdominals and the back is not as great, it's not as stiff as this muscle right here. So this is a video, if you'll play that video, to just depict this happening in an individual, and it's formed the basis of some of the laboratory analysis that we're doing. So hip lateral rotation is causing lumbopelvic rotation. So as soon as she moves with both medial and lateral rotation, she gets lumbopelvic rotation. Well, and then if we take a look and play this video, please, what do we see is that when she walks, guess what she gets? Lumbopelvic rotation. So the fact that she walks that way mobilizes her lumbar spine, and it's so mobile that something as benign as knee flexion or hip rotation causes the same motion to occur. So what does this mean to us? It means you got to stop the way she walks. It won't matter. I'm serious. So she rides everywhere now. No. No. So we had to teach her how to walk again so that she didn't get lumbopelvic rotation. And just to point out about personal characteristics, she's obviously has very broad pelvis. Well, it's not just because she's overweight, but I'm sure she has coxavera hips. And the reason why this plays into it is that when she's sleeping on her side, she goes into a marked side bend because her pelvis is so wide. Well, you do that night after night, and that mobilizes your lumbar spine into side flexion. So it keeps getting more rotation, and her hips keep getting stiffer and stiffer. Okay, so here's the whole flow of activity as we see it. Early lumbopelvic motion, increased frequency, accumulation of tissue stress, low back pain, persistence or reoccurrence. So all of our studies have been done in people with chronic low back pain, not acute low back pain. And of course, we know everybody that's acute will someday become chronic. We know they'll be back. Yes. Okay. So one of the ways we've looked at these relationships is to say, well, if moving the limbs causes the back to move because it's become so flexible, what if we just make them not move their back when moving their limbs and see does the pain go away? So these are some of the studies that Linda has published showing that if we modified how they move, their symptoms decrease. So if we look at our test, these are examples of the examination test. They're really kind of complicated. Knee extension and sitting, hip abduction, lateral rotation and hook lying, knee flexion and prone. But I think you're smart enough to get it. If you can speak 4 languages, you can do these things. Hip rotation and prone, hip extension and prone. And these are the numbers of people that had increased symptoms. As you can see, a big one is hip rotation and prone and hip extension and prone. And this became the focus of our studies. Now, if we say, okay, let's make you not move your back while you perform these motions, you can see the percentages of people with positive tests that all showed a decrease in their symptoms. So stop the back from moving when you're moving your limbs and you get a decrease in your symptoms. It's like that simple. Okay, so now we've gone on to get more sophisticated and do motion capture to look at some of these tests more critically. And so this is a person all dressed up for motion capture analysis. And what I want to stress to you here is what is the timing differences between movement of the hip versus lumbopelvic motion. Okay, so one of the studies that Linda and her colleagues did was to have people with back pain and people without back pain. And they did this little two simple movements. They were prone, they did knee flexion, and then they did hip rotation. Okay, and what did we find? And this is the way it was analyzed. We looked at this angle to see when did they start to move their hip, and then how soon did the pelvis start to rotate, lumbopelvic rotation. And this is the diagram of how the data was taken. The low amplitude movement, of course, is lumbopelvic rotation. The high amplitude is hip lateral rotation. And what we're looking at is the time difference between when one started and the other one followed. Now, the idea being that the bigger this time difference, the less likely they are to be injuring their back when they move their lower extremity, or how much less relative flexibility they have. So this is the way it works out, that if you do not have low back pain, it's like 0.3 before your lumbopelvic rotation starts after your hip starts to laterally rotate. While if you have low back pain, this starts earlier. The other things to look to make sure is how much range of motion there was. Well, actually there was slightly more hip lateral rotation range of motion if you had back pain than if you did not have back pain. And we made sure that they weren't moving faster that would cause this. So the velocity was controlled, and that was similar. Here's lumbopelvic rotation. And again, the maximum lumbopelvic rotation was actually a little bit greater in people that had low back pain than in the other people. This is just the time that I showed you before. Now, what about with knee flexion? And this was knee flexion performed actively, and I think what's interesting is there was no difference in anterior pelvic tilt during knee flexion, but there was a difference in pelvic rotation. Now, I think, again, that points out to me the evil motion is rotation. And I believe the evil motion is rotation because it's associated with shear, and that's the most destructive force. And also, it's the hardest to control, absolutely the hardest to control. So in people that did not have back pain, they had knee flexion for a longer period of time before getting lumbopelvic rotation than people who had back pain. And again, the maximum knee flexion was actually a little bit greater in the non-back pain people than in the back pain people, significantly different, but only 10 degrees. The velocity, again, was no different. So what about degrees? Well, this is sort of during knee flexion, the lumbopelvic rotation was greater. If you had back pain, the anterior tilt was not. And then we've already talked about time differences. So in summary, people with low back pain move the lumbopelvic region early during lower limb movements, and we consider that this may be an index of the movement pattern during everyday activities. These little simple things could be an index of what's really going on when you're out there performing. Hip lateral rotation produces early lumbopelvic rotation, knee flexion, early lumbopelvic rotation, much earlier than reaching the limit of muscle length. So this occurs very, very early when you start to move. Not late, very, very early. Now, the maximum knee flexion is less in low back pain. There's no difference in velocity. Maximum lumbopelvic rotation during knee flexion is about, and this is what I think supports the idea of relative flexibility, about 1 degree more. The timing is about 1 second earlier. So we're talking about little bitty differences. No difference for anterior pelvic tilt. And the lateral rotation angle is only about 2.5 degrees. Maximum lumbopelvic rotation during hip lateral rotation is about 1.5 degrees greater. So we're talking about mini aspects of things, not maxi aspects of things. Okay, so the lumbopelvic motion occurs very readily, elicited by lower extremity movement. And it's not primarily, it's not caused by short muscles. I think that's what's so important to realize. Stretching a muscle will never stop these movements. Stopping these movements will stretch a muscle, but stretching a muscle will never stop them. Okay, and that all this is very minimal, which to me I think is sort of the fun yet the challenging part. All right. Now, another aspect is looking at variations in relative flexibility with the different syndromes. So the syndromes that we're going to just talk about for a minute are people classified as rotation. That means they have pain with rotational type movements, or they have pain with both flexion and extension. Extension rotation patients have pain when the back is extended or when rotation is occurring. And these are often people that do asymmetrical sports that involve rotation to one side or another. And so again, the test is hip rotation and looking to see at lumbopelvic rotation. And now we're going to compare what happens to the pelvis when you rotate your right hip versus your left hip. So these are just to give you an idea of what we're looking for. If you look at the onset of pelvic motion with left hip lateral rotation and right hip lateral rotation, this would be a late onset, but there would be a high correlation between left and right. Early onset would mean they're really locked together, but there would be a correlation between left and right because they're both showing the same change. Okay. Now this is the way it came out. Yeah, also, if it's symmetric, it means that there's a high correlation. The time that the pelvis starts to move when moving the left is the same as when you're moving the right. If it's like this and there's no correlation, there's asymmetry between what happens moving the right leg and moving the left leg. Okay. Well, how did it come out? Beautifully. Meaning, the patients that were classified as rotation patients, when they moved their left leg and their right leg, the onset of lumbopelvic rotation was highly correlated, 0.94. If they were extension rotation patients, asymmetric, when they moved their right leg and they moved their left leg, they had very differences in the timing of their lumbopelvic rotation. So the people that we had categorized clinically, according to the different performances of their symptoms, turned out to have these very high correlations. Okay. Then the other part that we wanted to look at was, what about the relative stiffness issue? So we looked at side bending, and we looked at lateral side bending in standing, and we saw different patterns, again, according to the different classifications. And they paralleled the hip lateral rotation findings, which really means that the problem is in the back, and that asymmetry is from the relative flexibility. Okay, so let me just go on to kind of show you. We had 44 people in this, and with chronic recurrent low back pain. They regularly participated in rotation-related sports, and their symptoms were associated with these rotation-related sports. So again, here comes the motion capture system. They're all dressed up. They do side bending, and we look at the change in the angle in their lumbar spine. Isn't that cute? Okay. So specifically, we're looking at what happens in lumbar motion compared to thoracic and lower thoracic and upper thoracic. So this is the way the data looked. We looked at the onset of lumbar spine motion, the movement here at L1 compared to down here, then the lower thoracic segment and upper thoracic segment, and compared that to total lateral bending. And this is, again, to give you an idea of what we're looking for. Here's total lateral bending, and this is what's happening in the lumbar region during different phases. So what happened at 25% of the movement, 50% of the movement, 75% of the movement, and 100% of the movement. And if the pattern was symmetric, it would look the same whether you're going to the right or the left in the lumbar spine. But how did it turn out? It turned out, no, let me first do, an asymmetric pattern is that when you're going to the left, the lumbar motion is not the same as when you're going to the right. Okay. So we looked at the percent of contribution of the lumbar region at various increments, just as I told you, and then set up this little formula. And this is the way it turned out. Would you believe that in the rotation subgroup, that it was the same going to the right and going to the left? In the rotation extension subgroup, there was much more lower lumbar motion in the first part of the range, and then it became symmetric. And this was asymmetrical. So just like with the hip, when you went to the left, you got more motion in your lumbar spine if you were extension rotation. If you were rotation, that movement was the same in both directions. Okay. And what about stiffness? Well, we developed basically like a gravity-free table, and people were put on this table, and we measured their passive tension properties. And this is the way it looked, and again, it's the same kind of calculations. And we looked at the passive elastic energy as they were pulled from one side or to the other side. And this was to their end range, and this area was calculated. And what did we find is that we looked at looking at group differences, first people with no low back pain compared to people with extension low back pain. And there was asymmetry to a certain extent. One side had more passive elastic energy than the other side, but in no low back pain people, this was not significant. But when we looked at people with back pain, extension back pain, there was a significant difference between the passive elastic energy on one side compared to the other side. I should have had those fly in. Okay. And the end range of lumbar motion, again, there was a little bit of difference, the side of greater motion compared to the side of lesser motion in both people with low back pain than no low back pain. So the range of motion was not what was important. It was the passive stiffness that was the most important factor. Okay, so the increment of total low back pain motion to the left, total lumbar motion to the left, the condition at 25%, 50%, 75%, and 100%. So this is after treatment. Initially, they had 75% motion in their lumbar spine at 25%, and then it decreased as you went to the total motion. After they were treated, just taught not to move that way, it went down to 25%, so that we could teach people and get a change in how much their lumbar spine was moving. Okay, so summaries of these studies of relative flexibility. That spinal hypermobility, most reasonably accessory motion hypermobility, and I think we can start to call it micro-instability, though I've been adverse to that for a long time, is evident in our clinical exam and in laboratory measures. But what we can do in laboratory measures is look at the amount, and we can look at the timing. The lumbopelvic motion occurs earlier and with greater range of motion in patients with low back pain compared to controls. But these differences are in tenths of a second and just a few degrees. So this suggests that small but frequent motion is a source of stress on spinal segments and causes microtrauma to become macrotrauma. And that a contributing factor is the relative passive stiffness of muscles about a joint is a contributing factor. Now, I wanted to tell you one other thing that this is in the process of being published, and this is a randomized control trial that Linda Van Dillen did. And it was sort of a good news, bad news thing. So she got people with low back pain, and they were all examined, both clinically and with motion capture. They were then divided up into a category-specific exercise program and into a generalized exercise program. The people were seen once a week for 6 weeks. Now, seen, what that means is treatment is they were shown exercises to do, again, whether category-specific or general, and they were also taught to keep their spine neutral during functional activities. Now, functional activities means how do you roll? How do you go from supine to sitting? How do you walk? How do you get up and down out of a chair? Basic, keep it neutral things. So, what was the good news? Everybody got better for 6 months. They were seen 6 times once a week, and their pain scores went down for 6 months. Then there was a little upswing. The bad news was everybody got better. Meaning, how much I wanted the people that got category-specific exercises to do better than people that got general exercises. But what was the fatal flaw? The fatal flaw is that both groups were taught to keep their spine in neutral during all functional activities. The other thing that I think is a really big take-home message on this is that Linda has a wonderful case of OCD, obsessive compulsive disorder, which I think every good researcher needs. So what she also did was monitor their adherence to their exercise program or to their functional activities. And what do you think people did longer? Continue with their exercises or modify their functional activities? Functional activities. And there was a very high relationship. The longer they kept doing their functional activities correctly, the better they did. So now I do believe, and I think Linda shares this belief, that it's going to take about 4 weeks at least to get people to change their functional activities. In my clinical experience, once people's pain goes away, they don't think they need to do their exercises anymore because that's over with. Yeah, it's like, that's good because then you'll be back, so good. Keep it up. Anyway, so I think the important messages are we know people will get better if they keep their spine still during functional activities. We know that people will modify their functional activities once they've been carefully instructed, more so than they'll keep up with an exercise program. So that's what had the greatest effect. Okay, so spinal stabilization is an appropriate treatment. And I think because the spine is basically hypermobile. That's what all these little tests show. And that symptoms are elicited by spinal motion. When you move your limbs, it makes your spine move, which it shouldn't do. And then we decrease their symptoms if we prevent that motion. and that this imbalance in relative muscle stiffness is a big contributing factor. And the bottom line on that is it means you need to stiffen what elongates too easily, not stretch what doesn't seem to elongate well enough. And stretching a muscle, just to make this so important, will never stop this motion. It occurs too readily, too easily. And that the patient needs to be instructed in moving the appropriate joint, the hip, while not moving in the back. Now, these are all the people that have worked with Linda on this, and I thought, since I've sped through this, and I still have 5 minutes to go, right? I thought that I would show you a little bit of what we're looking at in other joints, so that we're not doing, there's some research in process, but we don't have all the data like I've shown you for the low back. And for the hip, we've put people also into categories. One category is called anterior glide with medial rotation, posterior glide, and these again are the offending motions, and they reflect joint hypermobility, not hypo, but hypermobility. And as you know, if you've worked with people with a frozen shoulder, you can have accessory motion hypermobility when you have physiological motion hypomobility. If you didn't, you wouldn't have pain. Yeah, okay, I'll show you. So here's the idea. If you did precise hip flexion, you would be able to drive an axle through the head of the femur, and you would just spin in the joint. And that one of the observations that we made early is that if you don't flex your hip precisely, instead of the perfect spinning, you get an anterior glide. And when the head of the femur anteriorly glides, it hits on the edge of the acetabulum. And that means you could injure that structure there. Now, not only, I'm well aware of the large heads of the femurs and all the rest of it, but this is another factor. Ooh, it's so scary. Anyway, you know, and Halloween is over, but we still put that up there. Anyway, so video. So what I want to show you here is the anterior glide sign that we look for in people that have hip joint problems. So again, with the idea that my thumb should be a parallel axle, so that when I flex the hip, my thumb should stay still if this hip is perfectly spinning. But as you can see, this femur is translating anteriorly. It's kind of a combination of what we call anterior glide with medial rotation. Now, this young woman was having hip pain. She's actually was a professional dancer. She's a physio now, taking care of professional dancers. And she's also Asian, so she's very flexible. So there was absolutely no hamstring resistance. Now I'm doing what I call a correction, which just means keep my thumb still, nothing complicated. And then I flex her hip the way it should flex. Now I'm going to ask her to take hold of it, and watch what happens when she takes hold of it. Actively contracts her muscles. Woohoo! There goes all that motion that shouldn't go. So it's flexion with medial rotation. Now that tells you the iliopsoas is not working correctly, or it would never medially rotate. That's what that tells you. And the hip has become hypermobile. Okay. Now let me go on and another aspect that we found too, and people do these incredible things, like try to posteriorly dislocate their hip. I know, they're on to the happy life now. They can put their chest on their thighs. And then they rotate medially and they rotate laterally. That is a good way to posteriorly dislocate their hip. So we have this posterior glide problem. So this is the same girl. Oh, does not get any better. But anyway, you play the video here. She talks and talks. It never stops. Anyway, so what I want to show you is that with this hip, that in her right buttock, there was something sticking out that wasn't sticking out her left buttock. So if I put this stick on there and I put my fingers behind there, that's a ½ an inch of difference between something prominent in her right buttock versus her left buttock. Okay, and then if I have her rock back, take my hands, I know my fingers are ½ an inch thick. There's something going on the right side that's not there on the left side. Now, if I put my hands on her sacrum, as she rocks back, you'll see that as she rocks back, the right side goes low compared to the left side. So there's something different in the way her hip is flexing. This is going low compared to the other side. Okay. Once more. Rock back, and this goes low. Now, if I put my thumb right there on this, I think it's the head of the femur. Do you see how it's medially rotating? And what it's also doing is coming out at me. So as she goes back, the head of the femur is going posterior and medially rotating. It shouldn't do that. It should be like on the left side where nothing happens as you rock back. Now, if I put my fingers on either side of the greater trochanter, you can see the same kind of thing. So again, I was explaining that there's something prominent on this side as compared to the other side. So we hold on here, and then I'll stop it after this. Have her rock back, and there goes the medial rotation on the right that's not on the left. So we call this a posterior glide with medial rotation. Now you can have anterior glide with medial rotation, or you can have both, and then it's hypermobility, accessory motion, hypermobility. Okay. So and I think the other part that's interesting is she's already had an ACL. Now that's a solid bone. That means if it's rotating up at the top end, it's rotating at the bottom end. Yeah, 5 minutes, okay. And then, I'm not bad, not bad. I didn't think I'd get to this, but I did want to show you, because I think observing these movement impairments is what's the critical issue. People can be high performance. Let me show you these shoulder things. I call these the big three of scapular problems. Decreased scapular posterior tilting, decreased scapular upward rotation, and increased scapular internal rotation. And these are all the studies that have shown that if you have shoulder pain, these are the faults that have been identified. Okay, and the humeral, same thing. Excessive superior translation, inferior, anterior. These are all the things we look for during our exam. And let me just show you, this is a video. So when this girl does shoulder flexion, she has it all bad. Meaning, that's internal rotation, not enough posterior tilt, not enough external rotation, not enough upward rotation. And what happens is she still has 180 degrees of shoulder flexion, which means her glenohumeral joint is hypermobile because her scapula isn't moving enough and it's not moving in the right place. Okay, and this fellow, this video, you play the one on the left, please. Okay, now most often, you see these faults on return, like that. You got it, right? You got it. That is internal rotation with insufficient upward rotation. Now, since it happened on return, it's not a weakness problem because eccentric is much stronger than concentric. So we shouldn't have a problem on return. Play the one on the right. Now, so what we do is teach them how not to do that. There's a whole lot of don't do that in this system. Did it play already? Oh, and you saw it, that we cured him. Here's another one. I think this is so wonderfully dramatic. Look at that. Okay, over here on this side. Oh, she's going to do it once more just to show that it really does happen. Here she goes. Now, this is all in the same session. See, what does it mean? It means that when she contracts her scapulohumeral muscles, it causes the scapula to move because the axioscapular muscles don't control the scapula. They don't have as much effect on the scapula as the scapulohumeral muscles. So the tail wags the dog, as I see it. Instead of enough stiffness and control from those muscles, but it's a training thing. It's not a strength thing. It's a training thing. The stiffness has to be changed. That's why they can modify it right away. That's what we try and teach them to do. So I just wanted to show you examples of these movement faults that can be categorized. We can put people into syndromes, explain the significant factors, and believe me, our profession will move on so much better if we put labels on conditions so people know we figure things out. Thank you very much.